Good morning, everyone. I'm Jim Pompiselli. I'm the Surgical Director for Liver Transplant. Today we have a hybrid in-person Department of Surgery Grand Rounds. Today we're going to have two speakers from our Donor Alliance, our local organ procurement organization, or OPO. Having been on the East Coast and now in Colorado for the last 5.5 years, I've had the opportunity to work with a couple of OPOs, and usually the relationship between OPOs and transplant programs sometimes can be confrontational or adversarial, but I'm happy to report that our relationship with Donor Alliance has been really more in the friends and family type category. We've really had a really good working relationship. Donor Alliance has invested a lot of money and resources in furthering the transplant programs here at the university, with investing in a lot of technology and material to make our jobs easier. And that was highlighted last week when we did our first ex vivo liver perfusion, a liver transplant case headed up by Trevor Neidham and Hunter Moore. We were able to put a liver on a pump for 11.5 hours and then successfully transplanted it, and the patient's doing very well. That's going to make, number one, transplant more of a daylight procedure rather than the middle of the night procedure, and also gives us the opportunity to take more marginal organs and assess them for viability before transplant. So as I said, we have two speakers. Our first speaker is going to be Jennifer Muriett. She's the Chief Operating Officer for Donor Alliance. She did her undergraduate degree at University of Phoenix and then got a master's in nursing from Grand Canyon University. She's going to be giving us some introductory remarks and some statistics. And then taking over for her will be Paul Lange, who's a clinical professor of medicine, nursing and medicine at Western Michigan University. He's also the chief medical officer for Donor Alliance, and both of them have a huge experience in organ donation. So they're going to be talking to us about best practices in donation science to maximize organ donation, generosity, and collaboration. I also want to mention that their collaboration with us goes beyond transplant. I think as of today, we're starting a collaboration with Marco Del Chiaro of oncology, where Donor Alliance is going to be giving some pancreas organs for research in the oncology division as well. So, Jen?
Thank you so much, Dr. Pompiselli, and we're very excited to be here, and thank you so much for having us. Wanted to get through the legal stuff first and let you know we have no conflicts of interest that are pertinent to this presentation. And wanted to also share with you that the information today in the presentation is all based on evidence-based practice and best practices throughout the U.S. for organ donation and transplantation. Wanted to share with you a little bit about our objectives and what we're looking to gain today when we introduce Donor Alliance and give you a little bit of information about our practices, as well as help to share with you practices that will narrow the gap between the weight for donation between recipients and donors, as well as differentiating the two different paths of donation and focusing on how we declare death, as well as looking at best practices for donor management and sharing you some of those tools and technologies that are up and coming that will help us to transplant more organs across the country. When we look at our presentations, we always start with our mission, vision, and values. And the Donor Alliance, our mission is simply to do two things, and that is to save lives through organ and tissue donation and transplantation, and to make sure we maximize these opportunities because they are few and far between. So we want to make sure that we're doing our best conversations, collaborating at our maximum capacity, and doing this through our core values, which are, we have listed there as ILEAP, and we really base that foundation off our people first core value, and in that, making sure that we're a dual advocate for both donor families and recipients, making sure that every donor has a choice and every recipient has a voice. I wanted to share with you First, the foundation, as Dr. Pompaselli mentioned, we are an organ procurement organization. We're actually one of 57 organ procurement organizations across the country. We're federally designated non-for-profit, and we have two main responsibilities, as I shared with you, and that's to procure organs and tissues for transplant. We're also an accredited tissue bank with the American Academy of Tissue Banks. And through our operations, in addition to serving the donor families, we serve our hospital partners with our core competencies of relationships through our hospital program development, through professional and public education to serve the community, as well as our donor family services, which serve our donor families, not only the day they make the decision to donate, we walk them through the process with them through the donation process, and then actually serve them for 18 months after the process to help them with their grief process and to honor their loved ones and the amazing gifts that they've given. A little bit more about organ procurement organizations and what that looks like across the country. As I said, there are 57 of us. This multicolored map gives you an idea of what that looks like across the country. For Donor Alliance, our donor service area, we serve all of Colorado and most of Wyoming, all but 3 counties in Wyoming because it's closer to Utah and that OPO serves there. We are the third largest organ procurement organization geographically. And so it gives us unique opportunities as well as challenges throughout the geography to maximize donation and make sure we have the best systems in place for our community. Also wanted to share with you a little bit about university, the program here for organ donation and tissue and the donation program here. As you can see, there's been a huge amount of growth for the potential for donation over the past 3 years. If you look back in 2019, there was only 20 potential donors here at the main campus at Anschutz, where this year through October, we've already seen a potential of 36 donors. And the biggest growth, if you look at the different breakdowns, we've had consistently strong donors after brain death, and we'll go into the 2 different types of donation, but also with donation after circulatory death, we've seen a huge amount of growth of organs that are available for transplant and maximizing these donors. As Dr. Pompaselli mentioned, some of this is due to the new tools and technologies that we have available, and we'll talk about that. But the other thing I really wanted to highlight here is this year through October, we have already done more organ donors this year than we've done any year prior at 14, and that's a huge compliment and to the hospital, its hospital partners, our relationship and the collaboration we have. And so we wanted to really thank you for all the opportunities and collaboration to make these happen for our donor families and the recipients waiting. Also wanted to share with you the tissue donation information and the people that have helped heal lives. As you can see, tissue numbers have remained relatively more constant, although we've had a lot more with the incidence of COVID and the increase of death rate. We have had a lot more referrals we've seen over the past few years as well. And as we continue to learn more about COVID, and Dr. Lange will share more with you about the opportunities for donation as we've navigated this virus along with you. To share with you the need across the country for organ donation, it is immense. As many of you probably watched the Denver Bronco game yesterday and their win, Empower Field seats about 76,000 people. And if you cram that stadium full of people, you would still not touch the national wait list. Currently, there are more than 106,000 people waiting for an organ transplant in this country, and almost 1,600 in Colorado and Wyoming. And when you look at the need compared to what's available, you think, oh, wow, Denver's got a lot of people in it. We serve 6 million people. And last year there were 44,000 deaths that we had. Yet despite that, if you drill that all down to the unique opportunity for organ donation, we're really down to about 1% of those deaths could even potentially be a donor. And out of that 1%, we had a record-breaking year last year with 215 organ donors and just shy of 1,900 tissue transplant. Tissue donation has a little bit more opportunity at 4%, but every conversation is a gift, a potential gift to save and heal lives. And so we want to make sure that we have the best conversations and the best collaboration to make that happen. Out of all these numbers, the 2 numbers that are most important and that I want to emphasize with you is 9 and 17. And they're important because every 9 minutes, somebody new is added to the wait list. in this country. And even more importantly, 17 people die every day in this country waiting for an organ for transplant. They're not waiting for some miracle cure, some new drug to be developed, or even some new research technology. They're waiting for someone to be kind. And we know that if everyone who could donate did donate, we would no longer have deaths on the waiting list. And that's why this process is so important and our collaboration is so important. Our vision is to make sure that wait list continues to grow smaller every year. And I do say continues to grow because back in 2015, the wait list peaked at 124,000 people. And we've actually seen continual growth in organ donation over the past 10 years, but we've also seen that affect the wait list. And it finally is coming down. And the daily death toll has also decreased from 22 to 17. So we are making strides. We just got to keep working. We want to make sure every family gets the opportunity to honor their loved one's decision to donate and the opportunity to make that decision if the individual themselves hasn't made it. And all of this happens through collaboration with our hospital partners, our community partners, other organ procurement organizations, and our transplant centers. Without this, all of us working together, none of this happens. And ultimately, our goal is to ensure no one dies for the lack of an organ transplant. So how are we doing on that? Well, we're doing pretty good in the fact that the deaths on the wait list continue to go down in Colorado. As you can see, despite the pandemic last year, we still had a decrease in deaths on the wait list. And for the past 2 years, we have not had a pediatric death, which we're really proud of, but we want the entire deaths on the wait list for Colorado and Wyoming to be 0. And that's what we strive for. Why is collaboration so important? I'm sure you've all heard the phrase that it takes a village to raise a child. It takes a village of experts in nursing, medicine, cardiology, pulmonology, hepatology, nephrology to do a donor. And without you, we can't do this. And so we want to make sure that we have that opportunity for families and to make sure that recipients waiting get the gift of life. So just to highlight, I wanted to share with you what could be donated, and this is, I'm sure, a review for everybody in the room, looking at the organ donor who could potentially save 8 lives. I will put an asterisk on that 8 lives because if we have a really nice, young, healthy donor who's in really good shape, we could actually split that liver and make it 9 lives as well. And I also wanted, while we're focusing predominantly on organ donation today, I did want to share with you that one tissue donor could actually heal up to 75 lives through the gifts that they give. To save a life, to save or improve a life from a death that we could not prevent is a miracle of medicine and a privilege of humanity. This is a quote from a donor family, and we've had many donor families share with us that they believe that donation is the best of humanity and the best that we can offer. And so I thank you so much for all of your collaboration and your gifts. I'm going to pass this over to Dr. Lange to share a little bit more with you about the medicine and the process of donation.
Thanks, Jen, for kicking us off. Before I start, I want to just thank Dr. Pompicelli for introduction this morning. Also want to thank the chairs of the Department of Surgery for the invitation this morning. Really excited to be here. I'm a critical care doctor by background, so I'm very intimidated here in the Department of Surgery. But I want to just say thank you for all that you do for my trauma and critical care colleagues. The lives that you save and try to save. Sometimes those can't be saved, and we appreciate the opportunity to collaborate with you. To our Department of Transplantation here at University of Colorado, thanks for all that you do to save lives and give those recipients a second chance. As Jen said, our burning platform is to eliminate deaths on the wait list. And what I hope to achieve this morning is not necessarily to fill your pail with information, but perhaps to light your fire for continuing to do what you do with the gifts that you've been given and to make a difference not only in the lives of the people you save, but also for potential recipients of life-saving organ donation. Okay, so no discussion around donation and organ transplantation can start without understanding the two pathways for donation. We'll walk through these very quickly. We have a range of learners this morning, so there's a little bit here for everybody. And some of this will be a review for some of you, and some will be new content. But two pathways for donation: donation after neurological death, referred to as DBD, and donation after circulatory death, or DCD. The key thing about donation, and it always occurs after death, not to not violate the dead donor rule. So first path to donation is brain death or donation after neurological death. In Colorado, this makes up around 60% of the donation, the donors we receive both from Colorado and Wyoming. As we'll talk about a little bit later, donation after circulatory death is really becoming a increasingly more common route for donors for Donor Alliance. Well, the number of organs that can be recovered from donors after brain death is significantly larger than DCD, although I'll show you some technology this morning that hopefully can start to bridge that gap. For those of you who've taken care of and deal with patients who may progress to brain death, this is a challenging process to work through with families, but it does give them a firm diagnosis of death. As you all probably know, the definition of brain death really didn't come to us until 1968 from the ad hoc committee of the Harvard Medical School, where they defined brain death as the irreversible loss of the whole brain, including the brain stem. This is further promulgated in 1980 with the Uniform Declaration of Death Act, which is really the basis of our brain death law. One is considered dead if you have irreversible cessation of either circulatory and respiratory function or all functions of the brain, including the brainstem, which is the Harvard definition of brain death. We could spend the next hour discussing all the nuances of brain death. It is particularly challenging for our clinicians who deal with that. This is still the most recent guidelines that we follow and clinicians follow. The American Academy of Neurology guidelines was updated in 2010. Really goes through all the details and nuances and ethics, if you will, of brain death declaration. For Donor Alliance, we're not in the brain death declaration business, but I think it's really important as we collaborate with our critical care community that Donor Alliance is required to verify death documentation. So our team will often huddle with you to make sure that the documentation is appropriate, it meets acceptable medical standards, meets hospital policy, perhaps more important, and there's a clear statement of death. Until we can have that sort of codified, we're not able to move forward with the donation process. So that's brain death in 2 minutes. The other pathway to donation is donation after circulatory death, or DCD. This is a situation where the family has decided to withdraw life-sustaining therapy. The patient is expected to die within a time frame that would allow organ recovery and transplantation. And most importantly, these are patients who don't meet the clinical criteria for brain death. So those of you in the transplant community know that organ transplantation really started in the 1950s with donation after circulatory death. So this is not a new process. Prior to the establishment of brain death in 1968, donors were legally and ethically acceptable. This was a legally and ethically acceptable form of death, and donations were done after cardiac death. So really through the late 50s, early 60s, most organ recoveries were from donors after donation after circulatory death. And then in 1968, we had the Harvard brain death criteria established. But there's really been a renewed focus on donation after circulatory death. The reason for that is, as Jen showed you, we have more people waiting for organs than the organs are available. So this is an opportunity for us to increase the number of organs available for transplant. But perhaps more importantly, it also addresses the growing request by families to fulfill donation wishes of their loved ones. Many people in our ICUs today, families are wanting to pursue donation. In the absence of brain death declaration, this donation after circulatory death allows families really to honor their loved ones' wishes. Couple key points for those of you who may not be familiar with donation after circulatory death. Again, this is a collaborative process with our bedside clinicians, as well as your organ procurement organization and the folks here at Donor Alliance. These are patients where the family is considering withdrawing life-sustaining therapy and considering end-of-life care. These are patients who are not expected to survive after the withdrawal of life-sustaining therapy. We will often huddle with the clinical team and other allied health personnel at the bedside to discuss these cases if there's a potential for brain death. If the family provides authorization for donation, then we will move forward in our process. Perhaps more importantly is these patients are not yet deceased, so Donor Alliance is not writing orders or managing these patients. They're still under the care of the clinical team, and our team will be there collaborating and supporting the donation process. As I mentioned, donors after circulatory death really provides an increasing source and utilization of organs that can be transplanted for our patients who are waiting for organ donation. And more importantly now, and I'll show you some technology here a little bit, that we are now able to really advance some of the thoracic organ recovery from donors after circulatory death. Next, I want to provide a very brief overview of some of the best practices for the management of the potential organ donor. These again are relevant to the organ procurement community, but perhaps more importantly, our critical care and trauma physicians who may be managing these patients as they progress from their devastating brain injury. The bottom line is good donor management is quality critical care. And I'll come back to that point several times. In the initial process of organ donation really requires a heightened awareness on the part of the critical care team. What we see often in our evaluation of potential donors is potential donors may be excluded by the critical care team based on notions of donor suitability or perceptions of conflict of interest or conflicts of care. Very important that the high quality critical care will allow us to continue to optimize organs that can be recovered from those recipients. And I'll show you some data here in a minute that good donor management in terms of reaching certain donor management goals really can allow more organs to be recovered from those donors who are declared brain dead. So what happens, again, for those of you who may be new to this, so once brain death declaration occurs, the OPO donor coordinators from Donor Alliance will come alongside and collaborate with myself as the medical director and also the clinical team. And we kind of collaboratively assume responsibility of the continuing management of that patient. We don't have enough time to discuss all the nuances of brain death. I'll talk a little bit about some of the physiology that occurs, but this initial process really requires a collaboration with you all who are at the bedside in terms of appropriate hemodynamic assessment. We sometimes need procedures that need to be done in the early evaluation for donor suitability, such as bronchoscopy and echocardiograms. So this is truly a collaborative process. After brain death, the medical management, if you will, then is assumed by the OPO or Donor Alliance. I want to talk just a little bit about some of the hormonal effects of brain death, because as a medical director of 2 OPOs now, I see many opportunities for our critical care teams to really anticipate some of the problems some of the challenges, I should say, that we inherit when we take over the management of these patients. You'll all remember that brain death is really characterized by a neurohormonal axis failure. So we get essentially pan-hypopituitarism. And also with that becomes a autonomic storm. And I would argue also a cytokine storm. Tremendous amount of inflammation after brain death herniation. So what we see in brain death is a decrease in antidiuretic hormone, decrease in T3, cortisol, and insulin. Obviously, decreased antidiuretic hormone is going to create a diabetes insipidus situation with massive fluid losses and concomitant hypernatremia. The absence of thyroid stimulating hormone and then the production of T4 and T3 causes cardiac cells to go into anaerobic metabolism. There's increased lactate, increased acidosis, and very commonly, if not universal, after brain death herniation, really a cardiogenic shock due to tremendous myocardial dysfunction. So we have a kind of a standard hormonal package, as every OPO does. For, again, some of my critical care trauma colleagues, of sort of a package of levothyroxine, which I'll talk about here in a minute, vasopressin initiation due to the near universal component of diabetes insipidus. We administer high-dose methylprednisolone and also insulin as well. We could go into a lot of the data or lack of data regarding hormonal resuscitation of the donor. I just want to make a point that Donor Alliance now is part of a multi-OPO clinical trial that's multi-OPO randomized controlled trial looking at T4 versus placebo. This study is being headed up by Mid-American Transplant. Gary Markland is the principal investigator. I believe 8 OPOs are participating. And hopefully, finally, we'll answer the time-honored question, does thyroxine have a role in donor management? There have been a number of published studies over the last 20 years that have supported one way or the other. The primary hypothesis in this study is that intravenous thyroxine will increase the proportion of hearts transplanted when given early after brain death to heart-eligible, hemodynamically unstable donors. As I said, after brain death herniation, there's a rude unhinging of the machinery of life, and that includes a complicated shock state, some of which is hypovolemic, some of which is cardiogenic, certainly a neurogenic component. Secondary hypothesis in this trial will be to look at, does T4 improve the hemodynamic stability of brain dead donors by decreasing the number of vasopressors and improving injection fraction, and then also looking, does T4 increase the number of organs transplanted per donor? Just one word, again, to my critical care trauma colleagues about management of diabetes insipidus, because this is probably the most common hormonal deficiency that we struggle with when we transition to the management of these patients and donors. Like I said, up to 90% of the donors are going to have low or undetectable amounts of vasopressin levels. As you know, clinically, this can result in massive fluid losses And that, concomitant with other forms of shock, can really compromise organ function and organ perfusion very early on in the brain death herniation period, sometimes even before declaration. So very important to keep your eye on the ball and resuscitate, provide prompt treatment for diabetes insipidus in the form of either intravenous vasopressin or perhaps even better, intravenous DDAVP. It's a more highly selective for the V2 receptor in the renal tubule, has a longer half-life than vasopressin, and it has a potent antidiuretic action. Vasopressin also may be additive or adjunctive. Obviously, it has a role in the management of shock, but also can provide some degree of antidiuretic hormone replacement. So the next few minutes, I want to really talk about what is something that most OPOs and myself are quite passionate about, and that's donor management. But I really paused and asked the question, does donor management really matter? So we have an amazing clinical team at Donor Alliance made up of our donor coordinators, who are most of them critical care nurses. Some of them you've probably worked with. Some of them are respiratory therapists, first responders, paramedics. They come to the bedside, and our focus as a team, we discuss these donors on a call before we start management, is to really focus on what are called DMGs, or donor management goals. Again, these aren't anything esoteric or complicated. The DMGs are really physiological parameters that target values that are really normal hemodynamic parameters: acid base, cardiovascular, respiratory, endocrine, and the renal status of the donor. So we are laser focused on meeting these goals. And here are our 9 donor management endpoints or critical care endpoints. Again, none of these are particularly controversial, but basic, what I call blocking and tackling of how to stabilize and manage organ donors. Targeting an acceptable mean arterial pressure, trying to optimize left ventricular ejection fraction, trying to optimize gas exchange, which the way we measure that is with the PaO2 over FiO2 ratio, acid base, some assessment of preload. You can argue CVP may not be the best assessment of preload, but we look at CVP, sodium below 155, glucose below 180, urine output more than 0.5 mLs per kilo per hour, and trying to minimize or optimize the vasopressor requirements in these patients. So these are our 9 sort of donor management goals. And our target is to obviously achieve all 9, but we consider 7 out of 9 achieving the bundle of donor management goals. And that bundle concept I'll show you in a couple papers here in a minute really has been shown to have significant effects on the number of organs that can be recovered from brain dead donors, but also, as I'll show you, has an effect on delayed graft function in kidney transplant recipients. So really the donor management goals were promulgated and pulled together really under the leadership of Darren Malinowski, who's a professor now at Oregon Health Sciences. Darren pulled together a number of the OPOs in Region 5 back around 10 years ago now, and really looked at where donors were in terms of achieving these donor management goals. And what he found was only 15% of donors at the time of authorization had these 9 endpoints met. And what he showed is that if you could achieve the bundle of at least 7 out of those 9 critical care endpoints met, you significantly improved your likelihood of achieving 4 organs transplanted per donor. So as you saw from the very beginning, we don't have enough organs for the patients who are desperately waiting for those. Your efforts in managing these patients early on in their in their brain death process really can make an impact on the number of organs that are ultimately recovered from these patients. And this paper back in 2012, published in Critical Care Medicine, was really the first paper that showed that meeting those donor management goals made an impact on the number of organs recovered and ultimately transplanted. Subsequently, Patel, an American Journal American College of Surgery, showed that as well, that meeting these donor management goals, not only at the time, if they were met at the time of authorization, which is really a reflection of good critical care, but also if they improved over time, really was associated with almost a doubling of the likelihood of achieving 4 organs recovered at the time of organ recovery and hopefully 4 organs transplanted. So number of papers subsequent to this have shown improvement in heart recovery, liver recovery, just by meeting the 9 critical care endpoints of donor management goals. These again are what our team focuses on when we're managing these donors. And I would just challenge our critical care and trauma colleagues that your efforts very early on in these patients can really make a big difference. What about the effects on the recipients who achieve these organs? Number of papers, again, I just picked these 2 that were published in American Journal of Transplantation, which showed that if donors met the donor management goals as defined by meeting the bundle, there was less delayed graft function in kidney transplant recipients. This paper on the left is from Darren Malinowski's group, published in 2013, and then the Canadians essentially reproduced this in 2019. So no discussion in healthcare today would be without some discussion around SARS-CoV-2 and COVID-19. So as we start to evaluate many of the patients in Colorado and Wyoming who may be candidates for organ donation, not surprisingly, many of them have or have had COVID-19. So can organs be recovered from donors with a history of COVID-19? Well, this is really a working document that really reflects really evidence-based literature. It's updated periodically from the OPTN as well as the Center for Disease Control, really trying to pull together all the relevant evidence that supports that donors with a history of COVID-19, some, not all, but some can progress to organ recovery and organ transplantation. So if you're looking for really kind of the most up-to-date advice and evidence, this is really the document you want to go to. I'm going to pull out a couple things here just to highlight. So at Donor Alliance, we have a process that we're following now in our evaluation of these potential donors that either have had or have COVID-19. We do independent testing, even if the hospital has already done testing, both nasopharyngeal and lower respiratory samples. As some of you may know, there was a disease transmission of COVID-19 in a lung donor very early on in the pandemic. And with that, then the CDC and OPTN made the recommendation or direction that all potential donors must have a lower respiratory sample sent for SARS-CoV-2, especially if the lung is going to be attempted to be allocated for transplantation. Those of you who have been living in the COVID world know that the PCR is a cycle threshold that's often attributed to it. It's essentially the degree of infectivity. Well, the CDC and the FDA now are currently really not recommending the use of the cycle threshold values in the assessment of the individual's degree of infectivity. That's a little bit of a pivot from early on in the pandemic. And also there's really insufficient evidence to support the use of antibody testing as a marker of assessing the safety or potential transmission risk to recipients. At Donor Alliance, we have, I think, recovered organs from 4 donors with COVID-19, and I believe 5 kidneys have been transplanted in the country. This, as you can imagine, is an incredibly dynamic state, and we've had multiple discussions with Dr. Pompicelli and his colleagues here at University of Colorado, just how to proceed with these donors that have had COVID-19. This is a paper published out of the Cleveland Clinic a few months ago, reporting on 5 donors, of which kidneys were recovered. These were unique donors in the sense that they really were asymptomatic for COVID-19, but screened positive in their donor evaluation. Younger donors, 10 kidneys were recovered and transplanted at the Cleveland Clinic. Short-term outcomes are very good. Long-term outcomes are still to be determined. I'll also mention too, in this 5-patient series, that 2 livers and a heart were also recovered for transplantation. So again, this is a very controversial and dynamic state. Where we are today probably doesn't represent where we're going to be in 6 months, but certainly every patient who has had or has COVID-19 may be a donor, may be a potential donor, and we would just ask that you collaborate with our Donor Alliance team so we can help you work through the nuances. Really, in the last 15 minutes now, I'd like to really present where I think the future really of organ procurement organizations is going to be in the next 5 years. It's already upon us, but really we're going to become organ repair centers. As Dr. Pompicelli mentioned, the burgeoning amount of technology now for ex vivo, both hypothermic and normothermic perfusion. I'm going to show you some data about normothermic regional perfusion. The team from the Department of Transplantation just returned from Scotland and did some training there on normothermic regional perfusion. Show you a little bit about that. But really, this is, we could spend a couple hours talking about new and upcoming preservation techniques. I want to just land very quickly on some kidney preservation techniques. This is really an excellent review recently published in Transplantation on advances in kidney preservation techniques. We have a group within Donor Alliance who's very expertise and committed to preservation technology. This is really a burgeoning area of research as well as implementation both on the industry and academic side. As you probably all know, that the time-honored process for kidneys has been static cold storage, and then moving into hypothermic machine perfusion. I want to talk to you a little bit about, as I'll show you a little bit later, some of the normothermic machine perfusion and as well as normothermic regional perfusion. But if you're interested in this area, I'd commend this really excellent review by Hosgood, published in Transplantation earlier this year. One study that kind of caught my interest because it's simple, and that's hypothermic oxygenated machine perfusion, or HOPE. This has been really studied in animals for a number of years, and experimental studies have shown that at hypothermic temperatures, the addition of oxygen during perfusion can really help support ATP synthesis, and in animal models, really prevented the deterioration of livers. This has also been looked at in a kidney model, and it does appear that oxygen appears to provide beneficial effect to the organs especially that have been subjected to a period of warm ischemic injury, which takes us back to our DCD population. As you all know, those organs are uniquely challenged because of the period of warm ischemia. So this is really providing oxygen during hypothermic machine perfusion, probably replenishes some of the oxidative stress and improves organ viability. And this was a study published in Lancet last year by Jockman's European group. This is the COMPARE trial, and basically looked at hypothermic machine perfusion with oxygen and hypothermic machine perfusion. As a multi-center trial in Europe, DCD donors greater than age 50, randomized double-blind paired phase 3 trial of around 200 patients. And they took one kidney and put it on oxygenated hypothermic machine perfusion, and the other was placed on hypothermic machine perfusion without oxygen. This is the COMPARE trial. And the results really showed very briefly that the primary endpoint of estimated glomerular filtration at 12 months, there was no difference between the two groups. However, there are some encouraging signals that oxygenated hypothermic kidneys may have benefited. There was lower graft failure in the group that received oxygen. There were less severe complications in the groups that was supplied oxygen during hypothermic machine perfusion. And there was also a relative risk of acute rejection, as shown by biopsy. So machine perfusion at hypothermic temperatures with oxygen may be another adjunct to our ability to preserve kidneys and hopefully optimize their outcomes. In the last 10 minutes, then I'd like to kind of go into some aspects of normothermic regional perfusion. If you're interested in this area, we'll just search these 7 ways that it's described. It goes by a number of different names, essentially using an ECMO circuit to oxygenate and perfuse organs. Dr. Pompicelli mentioned the recent ex vivo experience, taking a liver and putting it on a normothermic machine outside the body. I'm going to speak to you about really regional normothermic perfusion. So this is occurring in the donor in situ before organ recovery. Really, normothermic regional perfusion was described almost 20 years ago now. It's really an emerging technique that will perhaps and hopefully improve the quality of grafts from DCD organs and expand that donor pool. As I'll show you, it's been really advanced quite consistently in the United Kingdom and in Spain. And many OPOs and transplant centers are using it in the United States now. And then I'll show you some data on it being used in the recovery of hearts after donation after circulatory death. Well, some of the benefits of normothermic regional perfusion, really from a biochemical standpoint, is that normothermic regional perfusion can rehabilitate the organ in the body, really at the cellular level, probably by replenishing mitochondrial stores of ATP and perhaps reversing some of the anaerobic metabolism, if you will, almost mimicking a period of ischemic preconditioning. Normothermic regional perfusion can act as a perfusion bridge from the time of asystole to the time of procurement for our transplant recovery surgeons. This can permit some time for dissection and further minimize some of the risk of ischemic injury. And it really allows the surgeons to assess the organ under non-ischemic conditions over a period of time. And also during that time, our surgeons can trend some biomarkers and chemistries, be it of the liver or the heart, to make a decision about the viability of that organ for transplantation. So there are really two approaches to normothermic regional perfusion. Like I said, this has really been advanced in the United Kingdom and Spain. Abdominal regional perfusion is really the one technique. This supports the liver, the kidney, and the pancreas. Cannulas are inserted either into the iliac artery and vein or into the abdominal aorta and the inferior vena cava. And the thoracic aorta is occluded at the level of the diaphragm. So that's abdominal normothermic regional perfusion. Like I said, the team from University of Colorado is going to be advancing this. They just returned from Scotland a few weeks ago now. They got some training, and they'll be working with our team at Donor Alliance to really advance this technology across our donation service area. The second approach or second technique for normothermic regional perfusion is thoracoabdominal. This thoracoabdominal can support the heart and the lungs as well as the abdominal organs. In this case, the cannulas are placed in the right atrium and the iliac artery or the aorta. During this process, there's exclusion of the cerebral circulation in order to prevent any chance of perfusion or reanimation of the brain. So this is just one paper I pulled out, which really I think is quite compelling. It's a retrospective review from the group in the United Kingdom that looked at, again, in situ normothermic regional perfusion of livers after controlled circulatory death. In Europe, you may or may not know, they also they have donors after uncontrolled donation after circulatory death. So these are donors, patients who die pre-hospital, and for a country like Spain, that's an opt-out country, these patients can be placed on normothermic regional perfusion. Nevertheless, this is a nice paper from that group, Watson, published in the American Journal of Transplantation, a retrospective review of 70 DCD donors where 43 livers were transplanted. And it was compared to 187 non-normothermic regional perfusion DCD donors that had their livers transplanted at the same time. And the results were quite compelling. And as many of you know, livers recovered from DCD donors are quite at risk for cholangiopathy. So in this retrospective review, normothermic regional perfusion was associated with an overall reduction in early allograft dysfunction. There was a freedom of ischemic cholangiopathy, quite compelling in this retrospective review, and there are fewer anastomotic strictures in this retrospective study. So very encouraging results on the impact of normothermic regional perfusion to reduce some of the ischemic cholangiopathy and anastomotic problems that can occur in patients after liver transplantation from DCD donors. Well, recently now in the United States, in Europe, normothermic regional perfusion has been extended above the diaphragm and looking to optimize cardiothoracic organs, heart and lung recovery from donors after circulatory death. This also, as I alluded to a minute ago, really also offers an opportunity for the thoracic organs to be evaluated in the setting after circulatory death and really expand our donor pool, because historically recovery of thoracic organs after DCD donation has been quite limited. Certainly experience with some heart recovery and some lung recovery after DCD donation, but it's been fairly limited to some very aggressive centers across the United States. So this is really a paper published by the Vanderbilt group that is really probably leading the efforts in the United States around normothermic regional perfusion and cardiac or heart recovery. So these are DCD donors they're declared brain dead, or I'm sorry, they're declared dead after circulatory criteria. They have a waiting period, and then at this time, the cardiac team, in this case from Vanderbilt, will come in and place the heart or place the donor on normothermic regional perfusion. So this paper was just published, I think, a few weeks ago now, describing the first 15 patients from the Vanderbilt series. Again, we have been involved with one of these here in Colorado. I know University of California in San Diego is also getting their program getting up and going. And so we'll probably be seeing this more as we move forward. But nevertheless, the Vanderbilt experience, what they showed in these 15 patients was 6 of these recipients experienced mild primary graft dysfunction, 3 experienced moderate graft dysfunction, and no recipients experienced any severe post-graft dysfunction of their heart. Just want to drill down a little bit on some of the donor characteristics of these 15 patients. As you can see here, these are very young donors. As you might expect, if their heart is going to be recovered for transplantation, very young donors, their pre-donation left ventricular ejection fraction is quite good. Again, because they haven't experienced the brain death physiology, the catecholamine storm, the cytokine storm. They have really well-preserved left ventricular ejection fractions. And on the far column there, you can also see of these 15 donors where the heart was recovered, 13 had their liver recovered and proceeded with transplantation, as well as kidney recovery and even 3 lungs recovered. So thoracoabdominal normothermic regional perfusion really offers an opportunity to really expand and optimize our organs that are recovered after circulatory death. Finally, I just want to show some of the allograft intervals here. I've highlighted, again, the warm ischemic time for our transplant community. Functional warm ischemia time is really one of the key markers or metrics they look at in determining whether to accept an organ or not. In this series from Vanderbilt, these 15 donors had very short functional warm ischemic times, and the liver was recovered after 45 minutes of perfusion on the normothermic perfusion device. Finally, I want to end with perhaps the future, and that's xenotransplantation. Xenotransplantation has been around quite a while, but you may have seen this article or this published in New York Times, where I get all my medical information a couple months ago, where a pig kidney was genetically engineered and placed inside a donor and evaluated in a donor. So this donor, the family had consented to research. The team at NYU Langone, Dr. Robert Montgomery, led the surgical team. This kidney was genetically altered by knocking out a pig gene that codes for a sugar molecule that generally elicits a very aggressive rejection response. The kidney was then transplanted into a deceased donor, and it was maintained. The kidney was maintained, and the donor was maintained on a ventilator with the consent of the family for about 54 hours, and they observed both kidney function and for any signs of rejection. I don't believe this experience has been peer-reviewed yet, but nevertheless, I think this is really, another way that we may have the opportunity to expand organ availability. So with that, I'll stop. Thank you very much for your attention. Thank you for coming in person today. And we may have a couple minutes for questions. Be happy to answer any questions down here at the podium.
Thanks very much. We're actually out of time. I don't know if we want to have any questions coming up, but Jen and Paul, thanks a lot. We have the traditional swag bag from the Department of Surgery. And we appreciate everyone's attendance. Thank you very much.
Thanks. Appreciate it.